Pleural diseases. Anatomy of the pleura is a serous membrane which covers the lung, is composed of two layers. The inner one, visceral pleura, and the outer one is parietal pleura. There is a potential space which contains very small amount of fluid, from 10 to 20 milliliters, which is the normal amount, between these two layers. Innervation of the pleura, parietal pleura is supplied by both autonomic and somatic nerves, phrenic and intercostal nerves. Visceral pleura is supplied by autonomic nerves only, no pain fibers, and that's why during pleurisy the parietal pleura feels the pain and causes the stitching or stabbing pain. Surface anatomy of the pleura: 2, 4, 6, 8, 10, 12. Start by a curved line 2.5 centimeters above the medial third of the clavicle, sternoclavicular junction, then angle of Lewis at the midline. This is the second rib, number 2, from where it descends vertically downwards up to the fourth rib, then diverge left more than right. Right pleura is still in the parasternal 6th rib, out and down to the lower border, 8th rib in the mid-clavicular line, 10th rib in the mid-axillary line, 12th rib in the scapular line. Dry pleurisy. It's an inflammation of both layers of the pleura without effusion. The etiology: we have infection of the lung, bronchiectasis. It is the most common cause of recurrent pleurisy. Then we have pneumonia and lung abscess. Idiopathic: infarction, whether pulmonary or myocardial infarction. Irradiation: infiltration by a tumor. Immunological: whether SLE, rheumatoid arthritis, or FMF, familial Mediterranean fever. Clinical pictures: symptoms: chest pain, pleurodynia. It's due to stretch of the inflamed parietal pleura, because the visceral pleura is supplied only by autonomic nerves, not somatic nerve, and that's why it's painless. The character of the pain is stitching or stabbing pain, increased by inspiration and movement, reduced by breath holding. It refers to the ipsilateral shoulder tip by phrenic nerve when the area over the central tendon of diaphragm is affected, and to the upper abdomen by lower intercostal nerves when the area over peripheral diaphragm is affected. Dry cough, dyspnea, due to underlying cause, but can be false dyspnea due to pleuritic pain. Symptoms of the cause, just like pneumonia. Signs: pleural rub, due to friction of the rough two layers of the pleura, and signs of the cause, such as pneumonia. Investigations: we have investigations of the cause, pneumonia. Treatment: analgesia and treatment of the cause. We have Bornholm disease, which is a viral infection of the pleura caused by Coxsackie B virus or echovirus. It's a self-limiting disease. Clinical picture: upper respiratory tract infection followed by pleural pain which lasts for about 1 week. We have normal chest x-ray and the treatment is just symptomatic, but you need to know Bornholm disease, relate it to Coxsackie B virus, echoviruses, self-limiting, pleural pain just for 1 week. Pleural effusion: accumulation of fluid in the pleural space for more than normal, and the normal of fluid in the pleural space is 10 to 20 milliliters. The etiology: we have exudate, transudate, and blood. Blood like pneumothorax or esophageal rupture. Transudate: we have 3 causes: whether increased hydrostatic pressure, like pericardial effusion, pulmonary embolism, or chronic heart failure, or decreased capillary oncotic pressure due to malnutrition, liver cirrhosis, or nephrotic syndrome. And lastly, we have obstructed lung lymphatics, and this occurs in lung transplantation. Then we have the exudate. Any cause of pleurisy means increased capillary permeability because it's inflammation. The causes: we have infection, and it is the most common cause of exudative pleural effusion. Pneumonia, bacterial pneumonia. 40% of the cases have pleural effusion. Then lung abscess, TB, AIDS, and amoebic liver abscess. Infiltration by a tumor, whether from the lung, breast, lymphoma, or mesothelioma. Infarction, pulmonary or myocardial. Immune, SLE, rheumatoid arthritis, and Wegener's granulomatosis. Irradiation and iatrogenic by amiodarone. Clinical picture: it depends on the underlying cause, the amount of the pleural fluid, and rate of accumulation. But if you're gonna choose the most important thing that the clinical picture depends on, it would be rate of accumulation. Symptoms, according to the scheme: asymptomatic chest pain, dyspnea, and cough. Asymptomatic if there's a small amount or slowly accumulation of fluid. Chest pain, dull aching pain, but it can be stitching in inflammatory causes. Then dyspnea and cough. Signs: if the pleural fluid is more than 250, if the pleural fluid is more than 500 milliliters, the signs are evident. Inspection, palpation, percussion, and auscultation. Inspection: we have unilateral bulge, and respiratory movement is diminished on the affected side. Palpation, 3T, trachea and apex beat are shifted to the opposite side, decreased tactile vocal fremitus, and tenderness in case of pleurisy. Percussion: dullness to stony dullness over the affected area, with the highest level in axilla and in lower levels of the front and the back. S-shaped curve of Ellis. Then we have Skodiac sign, hyperresonance in the upper part of the lung above the effusion due to compensation by emphysema. Bruchus triangle, paravertebral triangle, triangular area of dullness at the back of the chest on the opposite side of the effusion. Auscultation, breath sound. We have decreased or absent vesicular breath sound. Bronchial breath sound may be heard just above the upper border of the effusion due to collapse, and this is called Garland's triangle. Additional sounds: we may hear pleural rub in case of pleurisy. So if you're gonna describe the pleural effusion, it's very important to mention Bruchus triangle, the paravertebral triangle, where we have dullness, Skodiac sign, where we have hyperresonance above the level of the effusion due to compensatory emphysema, and Garland's triangle, where we hear bronchial breathing above the level of the effusion. And finally, don't forget the S-shaped curve of Ellis, which is dullness over the affected area. Investigations. Radiology. Chest X-ray. It may be evident when the pleural fluid is more than 250 milliliters. We have specific finding and radiological signs of the cause and the trachea. The trachea is shifted to the opposite side. Radiological signs of the cause, whether it's lung abscess or pneumonia, and specific finding. It's divided into 3 parts. We can have fissural effusion, homogeneous opacity at the site of the fissures, or encysted pleural effusion, D-shaped opacity, or homogeneous opacity obliterates the costophrenic angle rising to the axilla, reaching up to total opacification of an entire hemithorax in massive pleural effusion. CT is more reliable than the X-ray for detecting of the effusion. Ultrasound can detect up to 200 milli of effusion. Number 2, we have diagnostic aspiration. It's divided into 3 parts: biochemical analysis, bacteriological examination, and cytological examination. Cytological examination for malignant cells, RBCs, YBCs. Bacteriological examination, pleural fluid culture for aerobic and anaerobic bacteria, and Zell-Nelson's test for TB. Then the biochemical analysis to differentiate between the exudate and the transudate type, according to Light's criteria. Light's criteria is divided into protein in the pleural fluid, then pleural fluid over the serum protein, LDH of the pleura over the LDH of the serum, then specific gravity. The exudate is always more than, and the transudate is always less than. So let's start. Exudate, transudate, proteins. The proteins in the exudate are more than 3 gram percentage. Pleural fluid ratio to serum protein is more than 0.5. Specific gravity is more than 1016. LDH is more than 200 international unit per liter. LDH of the pleura per LDH of the serum is more than 0.6. Then we have additional tests like glucose. It's low in TB or cancer, but it's very low in rheumatoid diseases, and it can reach less than 30 milligram percentage. Amylase, it's increased in pancreatitis, esophageal rupture, and malignancy. Lipids, milky fluid, rich in fat in case of chylous effusion. And finally, pH of pleural fluid, it's less than 6.8 with empyema. Sputum examination, culture and sensitivity test, but more importantly, we need to make sure of microscopic analysis to determine the infection origin, whether it's from the upper airways or the lower airways, pleural biopsy for malignancy and TB, thoracoscopy. Treatment. We have treatment of the cause, pneumonia, TB, lung abscess, pleurisy in cases of recurrent effusion, surgical lysis of adhesions may be required, pleural aspiration to relieve dyspnea, gradual under anesthesia. Now we have the special types of pleural effusion: parapneumatic, empyema, malignant, tuberculous, hemithorax, chylothorax, and rheumatoid effusion. Rheumatoid effusion, it's secondary empyema, common, high LDH, low complement, low glucose, less than 30 milligram percentage, and high rheumatoid factor. Cholesterol crystals are characteristic. Chylothorax, presence of chyle in the pleural space due to injury of thoracic duct, whether from a tumor such as lymphoma, idiopathic, or trauma. Treatment by ICT, surgery, or chemotherapy. Hemothorax, presence of a significant amount of blood in the pleural space, whether due to malignant pleural effusion, iatrogenic, central venous catheter, or chest trauma. Treatment by ICT drainage. Malignant pleural effusion, mostly due to pleural metastasis, rarely due to primary pleural tumor. Diagnostic aspiration show bloody and positive results on cytological examination, and it recurs after aspiration. Parapneumatic effusion, it's non-infected effusion, and it is the most common cause of exudative pleural effusion, because 40% of bacterial pneumonia is associated with pleural effusion, and it may progress to be complicated and infected to empyema. Empyema is presence of pus in the pleural space, and causes are pneumonia, lung abscess, or TB. Clinical picture, general manifestations of toxemia, clinical picture of pleural effusion, and it may be complicated by suppurative syndrome, by bronchopleural fistula, connection between the bronchus and the pleura, and this will result in cough with expectoration. Diagnostic aspiration, pH less than 6.8 and glucose less than the serum level. Treatment, antibiotics, and ICT drainage. Tuberculous effusion, clinical picture, fever, malaise, recurrent dry pleurisy, pleural effusion, pleural fibrosis, TB, empyema characterized by adhesions and calcifications, followed by active pulmonary TB. Investigations. Culture of pleural fluid is often negative. Pleural biopsy is diagnostic, and it shows tuberculous granuloma in 2/3 of the patients. Treatment. Chemotherapy alone is inadequate due to poor penetration of the anti-TB drugs, so it must be drained first by ICT, then surgical removal of calcified empyema is necessary. Pneumothorax. Presence of air in the pleural space. Etiological types and pathological types. Etiological types, we have spontaneous and traumatic. Traumatic from penetrating or blunt trauma, or iatrogenic pneumothorax, which follow procedures such as thoracentesis, pleural biopsy, rigid bronchoscopy, and mechanical ventilation. Etiological types also include spontaneous types, and is divided into primary and secondary. Primary occurs in absence of underlying disease. Family history may be present, cigarette smoking, and it mainly occurs in tall young patients due to rupture of subpleural apical blebs in response to high negative intrapleural pressure. Secondary spontaneous type is complication of pre-existing pulmonary disease, and you can remember them by air. A for airway diseases such as COPD, severe bronchial asthma. I, interstitial lung diseases such as sarcoidosis and interstitial pulmonary fibrosis. R for rupture of subpleural TB cavity or lung abscess. You need to know that amylase doesn't increase in sarcoidosis. It's a very important note. Then the pathological types, we have closed, open, and tension pneumothorax. Closed pneumothorax, air in the pleural space is with no communication with the atmosphere due to ruptured bleb, and it's mild. It resolves spontaneously because air is absorbed in the pleural space. Open pneumothorax, air is communicated with the atmosphere, and it may be due to trauma or something. Inspiration allows air to enter the pleural space and expiration allows air to go outside the pleural space to the bronchus, so there is mild compression on the lung. Tension pneumothorax, it's a life-threatening condition because the bronchopleural fistula has ball valve, one-way valve, and this allows air to enter from the bronchus to the pleural space, but it doesn't allow the escape of the air during expiration. So increasing air in the pleural space develops over time, leads to increase in the intrapleural pressure, leads to compression of the lung and the adjacent structures. Clinical picture. Symptoms. We have sharp unilateral pleural pain. Dyspnea, it depends on the underlying lung disease and the amount of the air in the pleural space. It's very marked in tension pneumothorax. Dry cough, shock with tension pneumothorax. Signs. General, simple pneumothorax have tachycardia and tachypnea. Tension pneumothorax has tachycardia, cyanosis, hypotension, respiratory distress. Local, we have no signs in mild pneumothorax. Inspection, we have unilateral bulge and diminished respiratory movement on the affected side. Trachea is shifted to the opposite side in tension pneumothorax, and we have reduced TVF. Percussion, hyperresonance on the affected side, and tympanic resonance in tension pneumothorax. Auscultation, decreased or absent vesicular breath found. Investigations. Blood gases, we have hypoxemia and hypocapnia. Pleural manometry. In closed type, pressure rises but remains negative, less than the atmospheric pressure. In open type, the pressure reaches 0. It's equal to the atmospheric pressure. In tension pneumothorax, pressure is progressively rising and it is more than the atmospheric pressure. Radiology, chest X-ray and CT. Chest X-ray, we have distinct visceral pleural line and absence of line markings outside this line. Jet black, collapsed lung, depressed copula of the diaphragm, and the costophrenic angle is abnormally deepened when the pleural air collects laterally, producing deep sulcus sign. Mediastinal shift to the opposite side, and small pneumothorax may only be seen in an expiratory film. So, to sum up, chest X-rays show collapsed lung, jet black outside the visceral lining of the pleura, depressed copula of the diaphragm, deep sulcus sign, deep costophrenic angle, mediastinal shift to the opposite side, and small pneumothorax may be seen on expiratory film. Differential diagnosis, causes of acute dyspnea with acute chest pain. Treatment. It depends on the severity of the pneumothorax and the nature of the underlying disease. Small pneumothorax, less than 20% of the hemithorax, resolves spontaneously. It just needs symptomatic treatment. Intercostal tube, ICT, the chest tube is placed under water-sealed drainage and suction is applied until the lung expands. The indications, tension pneumothorax, bilateral pneumothorax, recurrent spontaneous pneumothorax, patient on mechanical ventilation, or lung pneumothorax with more than 20% affection of the hemithorax, and finally, severe manifestations such as dyspnea. And this concludes our chapter.